those questions, Dr. Offit, you indicated to Mr. Kennedy when he was asking questions that one company had slowed down their process in order to get a diverse demographic group mix. Can you tell us who that company was?
It was Pfizer.
Okay. And I just thought it was interesting, and I had not heard that, so I appreciate that information. Also, I'd ask you and Dr. McClellan, AstraZeneca's phase 3 clinical trial was recently put on hold due to an adverse event occurring in one of its enrollees. The trials have resumed in the United Kingdom, Brazil, and South Africa. Excuse me. But to my knowledge, the trial is still paused in the United States.
Would you agree that this action taken by the FDA, excuse me again, signals a commitment to safety and not rushing the clinical trial process?
Yeah, actually, I think I can call out there first. I think first of all, the AstraZeneca vaccine trial in the United Kingdom was put on clinical hold twice, once in July and then the second time in September. And so when you do that, because there's so many investigators involved, that will always be known by the press and ultimately the public. The problem then becomes that you don't really know the details because confidentiality precludes you from knowing those details. And I've talked to the head of the Data Safety Monitoring Board in the United Kingdom about this, and he can't give me the details. And it's very frustrating for all of us because we think we know what those two cases were, but we don't. We also know that the UK regulators have now taken that clinical hold off because they presumably felt that this association was coincidental and not causal. But that hasn't happened here. And we don't know why the decision was made in one place or the other place. And that's part of the frustration of all this. I mean, people talk about transparency, but the fact of the matter is you can't really be transparent about these cases because of confidentiality issues. So it's sort of like, since Joe Kennedy's on this call, I mean, it's like driving in Boston. I mean, you're bound to have an accident. And I think that's the way this is set up.
Yeah,
I appreciate that. Yes, Dr. McClellan.
Yeah, just to add to that, I think it's also a reminder that this is a scientific process that is very much in process. And as you said, the FDA is right on top of this, watching closely. Before anyone gets broad access to this vaccine, there will be a public opportunity through that advisory committee review to go over this and any other significant safety issues that have come up during the clinical trials, and a chance for people like Paul. I know he wants to get that information now, but he will get his chance before there is any actual decision about this vaccine. And this is the way it goes with vaccine development. You know, these events happen, they need investigation, they need to be put in the context of the overall trial and all the rules and safeguards, including blinding and confidentiality that
I appreciate it.
That'll all happen before any decision comes on the vaccine.
Let me shift gears just because I see the clock ticking. Dr. Offit, there was an op-ed in the New York Times last week in which Dr. Peter Doshi, I hope I'm pronouncing that correct, and Dr. Eric Topol expressed concerns about clinical trials for the COVID-19 vaccine, stating, according to the protocols for their studies, which they released last week, a vaccine could meet the company's benchmark for success if it lowered the risk of mild COVID-19, but was never shown to reduce moderate or severe forms of the disease or the risk of hospitalization, admissions to the intensive care unit, or death. To say a vaccine works should mean that most people no longer run the risk of getting seriously sick. That's not what these trials will determine. Do you agree with those concerns? And either way, tell me why.
I don't agree. I mean, I think if you look at the natural history of people who are infected with SARS-CoV-2, if they have moderate to severe disease the first time they're infected, typically when they get a second infection, it's much more mild or asymptomatic. That was also true with the virus I work with, rotavirus, and it was also true with the rotavirus vaccine. I think they're exactly wrong. I think it's actually much harder to prevent asymptomatic infection or mildly symptomatic infection. If you can prevent that, you're much more likely to prevent moderate to severe disease. So I think they have it backwards. That's not really the history of vaccine development, so I think they're wrong.
All right, so since I already had it, what you're saying is if I get it again, it'll be mild.
And that's all you want. I mean, as a developer of a vaccine, what you want to see when you develop a vaccine is you want to make sure that natural infection can protect you against challenge. Then you know that there's hope for a vaccine. And when you see that, usually all you care about is that you can be protected against moderate to severe disease on reinfection, because that keeps you out of the hospital and out of the morgue. It's not usually the case where you're also prevented against having mild disease or asymptomatic disease. And if you look at the animal model studies for SARS-CoV-2, you can protect lower respiratory disease, i.e. pneumonia, but you don't really protect against shedding, which is to say asymptomatic infection or mild infection. So I honestly think that op-ed piece was just wrong.
All right. Thank you very much. I yield back, Madam Chair. My time is up.
Do we have Mr.